Okay, I say we take a break here. We'll come back in 5 and we take it again from the top.
Kevin, I can't afford to take a break right now. I'm way too stressed. I need to keep studying.
Patrick, I think you need to take it easy on the junk food. Aren't you a type 1 diabetic? I haven't seen you take your insulin at all today.
Kevin, I feel great. I don't need to take my insulin anymore, okay? You know what? I'm gonna go pee.
What, Patrick, what are you talking about? That's like the 5th time you've gone in this last hour. Why are you going to the bathroom so frequently? What's going on?
I'm sorry. I'm just so thirsty. I can't help.
Hey. Patrick, are you okay? I'm starting to get concerned about you now. Tell me what's going on.
Bananas up in the air where it's hot like peanut butter. Okay, you got it?
I don't understand. That doesn't make any sense. And why does your breath smell like that? It smells fruity.
I don't know, Kevin. You know, all I know is I gotta go to the bathroom right now. So I'll see you later, okay?
Patrick, are you okay? Patrick, I think you're having an emergency. I'm going to call 911. Hang in there, okay?
Our patient is showing signs and symptoms consistent with diabetic ketoacidosis, or DKA, a serious and acute complication of diabetes that typically arises from a deficiency or resistance to insulin. It is more common with type 1 diabetes and is often precipitated by stress or poor compliance to an insulin regimen. Insulin is required for the uptake of glucose by skeletal muscles and adipose tissue. Thus, low insulin or an insulin-resistant state results in hyperglycemia. Insulin deficiencies also stimulate lipolysis from peripheral fat stores, resulting in the release of free fatty acids. At high concentrations, these free fatty acids are converted into organic acids, collectively referred to as ketone bodies. These ketone bodies induce a state of metabolic acidosis. Patients will also experience decreased total potassium due to losses from frequent urination. However, the patient's measured potassium will appear either normal or elevated due to extracellular shift induced by acidemia and osmotic water movement. DKA is primarily characterized by a state of hyperglycemia. This results in polyuria by way of glucose-induced osmotic diuresis followed by polydipsia. The increased urination results in volume depletion, which may manifest as decreased skin turgor, dry oral mucosa, tachycardia, and hypotension. Neurologic symptoms may also be present, such as confusion and altered state of mental consciousness. Patient may hyperventilate to compensate for metabolic acidosis. And patients may also give off a fruity odor due to exhaled acetone. We will now observe as our patient's condition is assessed and managed.
Doctor, we just had a patient report to the emergency room. It's a 21-year-old Caucasian male with signs and symptoms of polyuria, polydipsia, nausea, vomiting, abdominal pain. They're type 1 diabetic. They had ANO times 2, and they didn't take their insulin today, according to their friend. They have no allergies. Their blood pressure is 160/85, pulse is 97, and they have mildly decreased skin turgor, mildly dry skin, and they're shaky and ill-appearing.
It sounds like DKA, but let me ask a few questions first. Did you guys do a urine analysis?
We did, and it was cloudy urine, there's ketones present, and it's negative for nitrates and glucosylcesterase.
Gotcha. What's the pH of the blood?
It is 7.1,
Bicarb levels?
16 milliequivalents per liter.
Okay, what about patient's blood glucose right now?
It is about 500.
And their potassium levels?
Potassium was 4.6,
And their sodium levels, please.
130.
Okay. Patient definitely has DKA. I'm going to call the pharmacist to make sure I order the correct meds.
Okay, sounds good. Thank you, doctor.
Treatment of diabetic ketoacidosis centers on correcting fluids and electrolytes and administering insulin to lower blood sugar. The first step of management is replacement of fluids, usually with normal saline, to correct hypovolemia and stabilize cardiovascular status. Insulin is administered intravenously as both a bolus dose and continuous infusion, and doses are weight-based. Unless levels are very high, potassium is co-administered with insulin because insulin will lower potassium by intracellular shift. Bicarbonate may be considered when pH is very low. Watch now as our medical team develops a treatment plan and adjusts as the patient's monitoring parameters change.
Hello, pharmacy. Can you send a pharmacist to help with a DKA patient, please?
Pharmacist on the way.
Thank you.
Hi, I'm the pharmacist. I heard you had a patient.
Yes, please. So we have a DKA patient. They're already on 1 liter of normal saline. What do I need to do now?
Since this patient is not hyponatremic, I suggest that we change his NS to half NS at 500 ml per hour.
Okay, what about the insulin part?
Oh, so since this patient is 91 kilograms, I suggest that we give him a bolus dose right now of 9 units of regular insulin, and then follow that up with a continuous infusion of 9 units an hour.
Gotcha. Do I need to be concerned about his potassium?
Oh yeah, so since the patient is going to be receiving insulin and his potassium is normal right now, I suggest that we give him 20 milliequivalents per liter of potassium in his NS bag.
Okay, thank you very much. Oh, one more thing. Patient is acidotic. Do we need to add sodium bicarb?
Looking at his pH, we do not need to give bicarb at this time. It is greater than 6.9.
Okay, gotcha. Thank you. We'll get the patient started.
Hi, sir. I'm here to give you some normal saline because you have lost a lot of fluids, and we're gonna also give you some insulin because your blood glucose is a little high.
Okay.
Okay, and do you have any questions for me?
Is it gonna make me feel better?
It should make you feel better.
Okay.
All right. Okay, you're gonna lay here, and then the doctor will be right with you.
Okay.
Hi, Nolan. PD patient, the DKA patient in bed 16, we've given him insulin for 1 hour already. His blood sugar is not dropping fast enough. What can I do now?
I think we can double his insulin dose to 18 units of insulin an hour.
Okay, I'll try that. Thank you. Hi, Nolan. You know that PD patient in bed 16, the DKA patient? So I just went over his lab values and it looks like the DKA has resolved. I want to change his IV insulin to sub-Q insulin now. What can I do?
So I think we should continue his insulin infusion IV for another hour or two, and then after that we can switch him over to his home dose of sub-Q insulin.
Gotcha. Thank you so much. I really appreciate all your help with this case.
Hey, Patrick.
Kevin, is that you?
Yeah, they say you're doing much better and that you'll be able to go home soon.
Really?
How do you feel?
I feel amazing. I honestly feel better than I did before, and I really learned my lesson.
Well, I'm glad things are going to be better now. But I got to say, Patrick, almost losing you like that made me think long and hard about my life decisions and my priorities. And I decided I'm going to go for it.
What are you gonna do?
I'm finally going to go and get my pilot's license.
Kevin, it's funny you say that. I was gonna tell you to do that. It's amazing.
Well, there's only one thing left to do now.
Let's fly.
We're doing it, Patrick. We're finally doing it.
Man, Kevin, this sure is amazing. It's beautiful out there, but it is a little foggy, isn't it?
Yeah, it is. It sure is.
What does that button do?
Touching everything.
What does that button do?
Patrick, no!
Oh my God, what is that?
Ah!